So now coming to the systemic QRP, systemic pathology, what all things we should know. Starting with first with the kidney topic, you should understand the crystals are one of the most important topics that will invariably come in exams. So you should be very clear. So let me give you a question and ask you this. So this was a patient who had a tumoritis syndrome and he's a CLL patient and he was given a cytotoxic chemotherapy. So this is a real case. This is an image which is given by my student Kanu Bansal, who is in US now. So this is his image. Okay. So what was this crystal? What are these crystals? So these are the typical crystals that were seen in patients of CLL. Okay. So look at these crystals here. These crystals here, which all of you can see this. So these crystals which you're seeing are uric acid crystals. Okay, so uric acid crystals, if you look at them, so whenever a patient has a tumor lysis syndrome, so first you should understand what is tumor lysis. So it's a double question basically. So whenever the patient has tumor lysis, the tumor breaks down. Okay, so the tumor breaks down. So tumor basically when it breaks down, so it has a lot of uric acid because it's metabolically active. So much uric acid can precipitate and cause uric acid crystals. Okay, apart from that, the phosphate levels are also increased. So remember always the phosphates increases and this phosphate binds with the calcium. So calcium levels in the body decreases. So whenever a person has a tumor lysis syndrome, the uric acid level increases. It can form uric acid crystals. Phosphate levels are increased and the iron that decreases in tumor lysis syndrome, this invariably is a question. So calcium is always reduced in tumor lysis syndrome. So this is one thing that everybody should be super clear with. Okay, so that's one thing which everybody should be very, very clear with, right? Now, once we are very, very clear with this, let's see. So we have seen the crystals of the uric acid. Let's see what are these crystals like. So uric acid crystals are typically like these, the image that I showed you. So they can be lemon shaped like this. They can be prism shaped. They can be parallelogram. So these are the uric acid crystals. And remember the image like this. So these are typical uric acid crystals and they're typically seen in acidic urine. So when I'm seeing acidic urine means what are the crystals which are found in acidic urine apart from uric acid crystals? That's another question that can be asked to you. So crystals which are seen in acidic urine are calcium oxalate crystals, uric acid crystals and cysteine crystals. Always remember a very simple formula, COUC. Okay, so remember this. Okay, so this is a couch. Okay, so acidic couch. Okay, so remember it is an acidic couch. Okay, so CO, why did I write? So that you don't confuse it. It is calcium oxalate crystal. Then U is uric acid and C is cysteine crystal. So they are acidic couch. Whereas when I say alkaline urine, so remember alkaline urine is alka. It's a 4-letter word. So first 3-letter words are called triple. And this A is your ammonium biurate. Okay, ammonium biurate. Okay, ammonium biurate. So remember that code is alka. Alkaline urine is alka. So first 3 words are triple phosphate and last A is your ammonium biurate. So that is one thing which everybody should be very, very clear with. Okay. So once you are very, very clear with this, now let's understand these crystals and see first acidic urine crystals. So starting with the first crystal here, these are calcium oxalate crystals. So remember these are like they are like envelope. Okay, so they are perfectly square crystals and they are like envelope. So these envelope shaped crystals are calcium oxalate crystals. Again, they are seen in acidic urine. Now let's twist the question. So look at this. These are your envelope shaped crystals. So these are calcium oxalate dihydrate. Okay, so whenever 2 water molecules are attached to it, this is dihydrate. It is envelope shaped crystal. But if they become monohydrate, they become like a bow. So they become like a bow. So that is calcium oxalate monohydrate. So if only 1 water molecule is attached to it, they will become monohydrate. So that's one you have to remember. This is very clearly that everybody has to remember. Now, once we remember this, and also remember there are very rare calcium carbonate crystals also. So these calcium carbonate crystals are with striations and they are very unique because they're carbonate. So they are found in alkaline urine. So this is a very rare crystal. But if they ask you calcium carbonate, okay, is the crystal which is found in alkaline urine. Whereas calcium oxalate crystals are always found in acidic urine. Remember acidic couch, okay. And if I'm saying that acidic urine, you have to remember that these crystals are always calcium oxalate crystals are always so they are always like a envelope. Okay, so they are perfect square. That's what you have to remember. So they are envelope shaped crystals. Okay, now once we are very clear with this, Okay, let's go to the next crystals in the acidic urine. So CO is over, U is uric acid. We have seen it is like parallelogram, and again they are seen in whenever the patient has tumor lysis syndrome. Okay, apart from that, you have to remember the cysteine crystals. So cysteine crystals are like stop signs. So they are like stop signs. So whenever we have stop sign, it is like stop sign like crystal. These are cysteine crystals that you have to remember. Now coming to the alkaline urine. So alka is first triple. So when I say triple phosphate, remember these are true white stones. So first thing, remember they are rectangular crystals. Okay, so they are rectangular crystals and they are like coffin lid. Okay, so they are like coffin lid. Okay, so like this and a line here. So they are like coffin lid. So these are your triple phosphate crystals. They are like coffin lid crystals which are seen. And why they are called triple phosphate? Because they have three things in them. They have magnesium, ammonium and phosphate. So they have magnesium, ammonium and phosphate. So these are the three things which are there, which you should always remember. So they have magnesium, ammonium and phosphate. So that is very important, and these stones are called as true white stones. So they are also called as true white stones. Okay, so they are true white stones. Okay, so they are also called as true white stones that you have to remember. Okay, so these are your triple phosphate crystals which everybody should be super clear with. Now, coming to the ammonium biurate crystals. So, ammonium biurate crystals are like thorny apple. Okay, so they are like thorny apple crystals. So, these thorny apple crystals are also seen in alkaline urine. So, they are thorny apple crystals and they are seen in alkaline urine. So, remember these are thorny apple and they are also seen in alkaline urine. These are ammonium biurate crystals. Okay, so that is like a thorny apple crystals. Okay, so these are the common crystals that everybody should remember, and these are the crystals that they ask you in exams. So, you should be super clear with these crystals. Okay, so once you're clear with the crystals in the urine, the next thing that they ask you is the casts in the urine. So now let's come to the casts. What are casts? Cast mean when something gets deposited in a shape. So what happens is, basically whenever something is passing through the tubules, distal convoluted tubule has protein called as Tom Horsfall protein. Okay, so what is this protein called as? Tom Horsfall protein. So this forms the base which traps whatever is passing through the tubules and it gives it a shape, a cast. And that cast comes in the urine. So that is what is called as a cast. Okay. So now whenever we talk about something coming out, it can be either acellular, that is nothing is there in that cast. It's just Tom Horsfall protein which is coming out with some secretions. You don't see cells in it. So that is called acellular cast. Most common cast in humans is a hyaline cast. That is, nothing is there. This is Tom Horsfall protein with some secretions. So these are seen even when we do strenuous exercise. So these are hyaline cast. Now, we can have other types of acellular casts also, like for example waxy cast. Okay, so what is waxy cast? So waxy cast is a evidence of chronic tubular injury. So whenever there is very chronic tubular injury, so tubules usually when they get injured, okay, so immediately when they are injured, what happens is they break down and they get trapped in the Tom Horsfall protein. So these entrapped tubules usually are crushed and they turn into granular cast. After a point of time, these granules are resorbed. They are resorbed and they turn into complete waxy cast. Okay, so these tubules, these granules are resorbed and it becomes waxy. So what happens in waxy is that the outlines of the Tom Horsfall protein are well defined. So the casts become well defined. Okay, so they don't have any internal structure because the granules are resorbed and you have a well defined outline. So these are what are called as waxy cast. So waxy cast indicate chronic tubular injuries. Okay, then we have fatty cast. Sometimes whenever a patient has lipiduria, whenever the lipid is passing in the urine, then what will happen is this lipid can get trapped in the Tom Horsfall protein and it can come out. So this is usually seen in the patients of nephrotic syndrome. So whenever we have a person of nephrotic syndrome, two things can happen. So let us say this is the kidney and the person is having lipiduria. So what can happen? Either the proximal convoluted tubule can take in lipids. So this lipid which is there in the proximal convoluted tubule can come in the urine after the life of PCT is over. So these PCT cells with fat can come in the urine. So these are what are called as oval fat bodies. What are they called as? Oval fat bodies. or the lipid is getting secreted. So it will come, this lipid can get trapped in the Tom Horsfall protein and it comes out as fatty casts. So they come out as fatty casts. So can I say in patients of nephrotic syndrome, we can have oval fat bodies and fatty casts. So how do you see them? So if you see this oval fat body under polarizing microscopy, it will give you Maltese cross appearance. So this is a very characteristic point that you have to remember. And this is a super special box that I'm drawing here. This super special box says, whenever you are seeing Maltese cross in pathology, so in the urine, if you are seeing the Maltese cross, this is for oval fat bodies. Otherwise, in blood, Maltese cross appearance is seen in Babesia. So this is an organism called Babesia, which will show you Maltese cross. Now, talking about the cellular casts, we can have RBCs which can be trapped in the Tom Horsfall protein. This is usually seen in acute glomerulonephritis. We can have WBC trapped in the Tom Horsfall protein. This is seen in acute pyelonephritis. Or we can have any cells like tubules. When they get damaged, they can be trapped in the Tom Horsfall protein. So these tubules get crushed and they change into granular cast. So they will become like small granules. So these are important casts that everybody should be super clear with. Okay. So once you're clear with this, let's look at them one by one. Look at this cast here. So you can't even see it well with the naked eye or under the microscopy. So what do you see? You close the diaphragm, you condense, you put the condenser down and you see them. So then you can see some hyaline material here. So these are what are called as hyaline cast, and they are even seen whenever a person has strenuous exercise. So this is one of the most common cast that you see in the urine. Looking at the other one, the hyaline casts are best seen with the phase contrast microscopy. So that's the microscopy which we use to identify the hyaline cast. Remember, this microscopy is very important. So phase contrast microscopy is basically used whenever you have to see some moving structures like hairy cells or hyaline casts. So that is the condition where you see these hyaline casts. Okay. Now, once you're very clear with this, next thing that you have to remember is this cellular cast. Now, this is the base of the Tom Horsfall protein, and you're seeing some WBCs trapped in it. So these are WBC cast, which is seen in acute pyelonephritis. Or one of the very important casts that you see is acute tubular necrosis. So whenever a patient has acute tubular necrosis, so these necrotic tubular cells get trapped inside the Tom Horsfall protein, and these necrotic tubules give an appearance of muddy brown cast. So these muddy brown cast, whenever you see, this means the patient is having acute tubular necrosis. So muddy brown casts are very suggestive of acute tubular necrosis, which everybody should be super clear with. Okay, now look at these casts, guys. What do you see here? These are granular casts. So there is a shape to this, but you can't see the structure of what is inside them. So you just see some granules, a lot of granules inside the cast. These are called granular casts, and they indicate tubular injury. So whenever we have tubular injury, then you can see these granular casts. Okay, so granular casts are basically indicative of tubular injury. But remember, when the tubular injury becomes chronic, these granules are resorbed and they change into waxy cast. So remember, in this crystals, in this image, you're seeing two types of cast. One is the granular cast, that means the tubular injury is occurring. And second is the waxy cast. So waxy cast means chronic tubular injury. So that means the tubular injury has become chronic now, and that is why you're seeing the waxy casts. Remember, why and how are they different from hyaline cast? Because their outlines are very well defined. Okay, so these waxy casts are appearing like a wax strip. So you just remove the strip from the candle and see how it appears. It appears waxy. The outlines are well defined. So that is what is called as a waxy cast. Okay. Now, once we see that, do not confuse it with broad casts. So broad casts are very broad in nature. Okay, so they are very, very thick. Okay, they are broader cast, and broad cast indicate chronic renal failure. So broad casts are seen in chronic renal failure. So that should be very clear to everyone. So can we revise these casts quickly at one go? So if you're seeing muddy brown cast, this is acute tubular necrosis. If you're seeing waxy cast, they are chronic tubular injury. If you're seeing broad cast, these are chronic renal failure. If you're seeing WBC cast, this is acute pyelonephritis. If you're seeing RBC cast, this is acute glomerulonephritis. Fatty cast is nephrotic syndrome, and most common cast seen in human is your hyaline cast. So let's look at the question which came in your INICET exam, and let's see how many of you can answer this. So this was the question. So this is a post-renal transplant patient presents with decreased urine output. The urine analysis was done and shows the structure which is shown. What is this? So you can see this, the outlines are not well defined. This structure like a cast which is coming. So definitely this is a hyaline cast. But let's understand the other things also. So what are these decoy cells, which is very important because this is a post-renal transplant patient. So this becomes very, very important. Remember, whenever the patient is post-renal transplant, his immunity is decreased. In such cases, the patient usually gets infected by polyoma virus. So these polyoma virus inclusions can be seen in the tubular epithelial cells. So whenever these tubular epithelial cells are shed in the urine, the big inclusions can be seen inside the cells, and these proximal convoluted tubule cells, when they shed in the urine with these inclusions, these are called decoy cells. Let's look at them. So if you look at the decoy cells, what are these? Can you see these cells with, so these are your PCT cells and they have a big inclusion here. So the big inclusion is giving the nuclear the clear appearance. So this is a very clear appearance of the nucleus, inclusion in the nucleus. So these cells are called as decoy cells. Please remember, if you look at them on the biopsy in the tubular epithelial cells, they will appear as these are tubular epithelial cells with the inclusions. So look at the normal tubular epithelial cells to identify this. These are the normal tubular epithelial cells which you can see normally. And can you identify these epithelial cells with the large inclusion inside them? So these are polyoma virus. If you do the electron microscopy, guys, then also you will see these small virions which are present in the tubular epithelial cells. These small virions are nothing but polyoma virus. So remember, this is a very important question that comes in the urine, especially in the urine when you see these large cells with large clear inclusions. These are polyoma viruses. Okay, so this is one thing which you should be clear. So when we are talking about urine, it is not complete until and unless you see the Maltese cross appearance on the polarizing microscopy. So these are your oval fat bodies which come in the urine, and if you see them under polarizing microscopy, you will see this Maltese cross appearance. So this Maltese cross appearance is very typical of oval fat bodies which are seen in the urine. Okay, so if you are saying that what all things have you till now studied that you can see under polarizing microscopy, so remember, oval fat bodies will give you Maltese cross appearance. This is seen in nephrotic syndrome. Second, do you remember apple green birefringence on a Congo red stained slide? This was very typical for amyloidosis. This is also seen on polarizing microscopy. Third is your gout. In gout, remember the code GUN. Okay, so gout has has urate crystals, okay, sodium urate crystals, and they are negatively birefringent. Okay, so GUN is negatively birefringent, whereas pseudo gout is because everything in P, so they have calcium pyrophosphate crystals and they are positively birefringent. So they are positively birefringent. So that's pseudo gout, P for P, everything. So these are some things which you should remember in your polarizing microscopy, and you should not do them wrong. Whereas phase contrast microscopy, you have seen two things. One is hyaline cast and the second is hairy cells in hairy cell leukemia. So these are some conditions that should be very clear to you, right? Once we are very, very clear with this, okay, next thing that you have to understand and you have to see this here is, so once we are clear with the cast, let's, before we finish the casts and the crystals, let's see one question which was asked recently. So the question said 25-year-old female who had ethylene glycol poisoning. So which crystals are seen in them? So whenever ethylene glycol poisoning occurs, this glycol changes to glycolic acid. This gives an acidic pH, and what happens is the oxalate gets trapped in it. Okay, so the oxalate gets trapped in it and it catches calcium and it forms calcium oxalate crystals. So usually you see calcium oxalate crystals, and remember monohydrate crystals are more than dihydrate crystals, and as you remember monohydrate crystals are bow shaped crystals as compared to dihydrate, which is your envelope shaped crystals. So remember monohydrate crystals are more commonly seen in ethylene glycol poisoning. So these are some questions which are commonly asked in casts and crystals which you should be knowing. Now, next common thing that they ask you in kidney is nephrotic and nephritic syndrome. So, nephrotic syndrome patients usually present with number 1, proteinuria. Okay, because of this, they have hypoproteinemia, lipiduria, but liver compensates and they have hyperlipidemia. So, nephrotic syndrome, if somebody asks you what is the most common cause of nephrotic syndrome in child, all of you should remember it is minimal change disease. Most common cause of nephrotic syndrome in adult, it is focal segmental glomerulosclerosis. Most common cause of nephrotic syndrome in elderly, it is membranous nephropathy. So these are stat questions that they ask you. Remember, majority of the nephrotic syndromes are because of the damage to the podocytes. So they are called as podocytopathies. And one more point to be added in podocytopathies, diabetic nephropathy. So diabetic nephropathy is also a podocytopathy. So if somebody asks you what all are the podocytopathies, the minimal chain disease, FSGS, membranous nephropathy and diabetic nephropathy. Coming to the glomerulonephritis. So if I'm talking about glomerulonephritis, what is the most common cause of glomerulonephritis in the world? It is IgA nephropathy. Most common cause of glomerulonephritis in India, it is post-streptococcal glomerulonephritis. Most common cause of end-stage glomerulonephritis is rapidly progressive glomerulonephritis. Remember, there is a condition called as membranoproliferative glomerulonephritis, which can present with both nephrotic and nephritic. So that's one thing that all of you should be very clear with. So these are some spectrum that can be given because they can be simple question. Which of the following is not a nephrotic syndrome? Minimal chain disease, FSGS, membranous, IgA nephropathy. So IgA nephropathy is the most common cause of glomerulonephritis. Plus, majority of the kidney questions are history-based questions. So whenever they are giving you a history of hematuria, hematuria, oliguria, hypertension, azotemia, you should think of glomerulonephritis. Whenever they're giving you a history of proteinuria, hypoproteinemia, lipiduria, hyperlipidemia, you should think of nephrotic syndrome. So that point should be clear to everybody. Now first, let's start with the nephrotic syndrome. So as we have talked about the 3 important causes of nephrotic syndrome, we know what are the 3 important causes of nephrotic syndrome? Minimal chain disease, FSGS and membranous. So minimal chain disease, name itself says it's a minimal chain disease. So you don't see any finding on the light microscopy. Okay. So there's no finding on the light microscopy. Only thing is that the PCT cells are filled with lipids. So this is also called as lipoid nephrosis. Okay. Now, what do you see on electron microscopy? You know this is a podocytopathy. So there is foot process effacement. Okay, so foot process effacement will be there. And because this is not an immune complex mediated disease, on immunofluorescence, this is not an immune complex mediated disease. So what will you see? So here you will only see, there will be no deposits. Nothing will be seen. It will be negative. So this is basically a disease which occurs because of T cell dysregulation. So there is a T cell dysregulation which occurs here. T cell dysregulation occurs here. And there is production of lot of cytokines. So remember, the condition which produces lot of cytokines can cause minimal change disease, and the classical example is Hodgkin's lymphoma. So patients with Hodgkin's lymphoma usually develops minimal change disease. Now coming to FSGS, remember FSGS name itself says focal segmental glomerulosclerosis. Focal means when less than 50% of the glomerulus is involved. Segmental means in one glomerulus, partial glomerulus is involved. So it's focal, less than 50% of the glomerulus are involved, and those which are involved are segmentally involved. So this usually occurs whenever there is extensive podocyte damage, and the condition which causes extensive podocyte damage can be remembered as HORSE. So HORSE means HIV and heroin drug abusers, massive obesity, reflux disease in the kidney or renal ablation, and sickle cell anemia. Okay, so these are the conditions which causes FSGS, and of course light microscopy is the name itself. It shows you focal segmental glomerulosclerosis. On electron microscopy, foot process effacement only, and immunofluorescence there is non-specific trapping of IgM because there is a sclerosis. So there is non-specific trapping of the IgM. So let's look at the image and if there is a gene involved. So look at this image here. So there are three glomeruli which are seen. In one glomeruli, it is segmentally involved. So this is a classical image of FSGS. Remember, what is the gene typically involved here? You should remember here. It is ApoL1 gene. Okay, so ApoL1 gene. This gene is on chromosome number 22. And this is usually seen in Africans to protect themselves from trypanosoma. Okay, so this is a protective gene from trypanosoma. So if there is a mutation in ApoL1 gene, this usually causes FSGS. Okay, so this usually causes focal segmental glomerulosclerosis. So that is what you have to remember, and that's the gene of focal segmental glomerulosclerosis. Now, once we are clear with this, so let's quickly see what are the findings. So let's quickly see the findings of the FSGS. So if I'm drawing a box here, okay, so we have to see all these three so that we remember. Light microscopy, the change itself less than 50% of the glomeruli, and that which is involved is segmentally involved. Electron microscopy is foot process effacement, same thing. So on electron microscopy, we cannot differentiate between the minimal chain disease and FSGS. And if you do immunofluorescence, because there is a sclerosis, there is a non-specific trapping of IgM. And again, it's not an immune complex mediated disease. Okay. So there's just non-specific trapping of IgM. Coming to the third one, guys, so membranous nephropathy. So whenever I'm talking about membranous nephropathy, you have to remember the name itself says membranous. It is a membrane formation. Remember what happens in this? This is an immune complex mediated disease. So whenever we have an immune complex, you have to ask what is the antigen. So the antigen which is proposed here is phospholipase A2 receptor. That's the most common antigen which is there. There is a recent update also which I'll show you with the question. So whenever this is an antigen, antibody is formed against this. So antigen-antibody complex goes and deposits in the subepithelial location. Okay. So these are the podocytes here. Okay. So the location, please remember to hear the stories that are told in the NEET PG sessions in the app. So remember the deposit is between the basement membrane and the epithelium. So it's below the visceral epithelial cells. So podocytes are also called as visceral epithelial cells. Okay, so they are also called as visceral epithelial cells. So it's below the epithelial cells. So that is why the deposits are called subepithelial deposits. So you see subepithelial deposits which can be seen on electron microscopy. And to protect the podocytes from falling down, the basement membrane starts proliferating to reach till the podocytes. And in a view, it comes either as spikes or it can form the domes. So spike and dome pattern which is seen is because of basement membrane proliferation. So this is because of basement membrane proliferation, which you can see on the special stain, either on PAS stain or on the silver methamine stain. So you can see either on the PAS stain or on the silver methamine stain. So you will get spike and dome pattern here. So again, if I'm talking about membranous nephropathy and I draw a box here. So what do you see in the light microscopy, electron microscopy and immunofluorescence? So on the light microscopy, what do you see is that the basement membrane is proliferating in spike and dome pattern. So the basement membranes are thickened. So the basement membranes are thickened. That's the only finding that you see here, that the basement membranes have become very, very thick. On electron microscopy, you see subepithelial deposits. And of course, it's an immune complex mediated disease. So along with the antibody, you will see deposition of complements here. So all the complements are also deposited in the immune complex. So wherever the immune complex is deposited, complements are deposited along with that. So this patient typically presents with hypocomplementemia. So very simple question, which nephrotic syndrome presents with hypocomplementemia? It is minimal chain disease, hypocomplementemia. So is everybody clear with this? Okay, so now the basement membrane is thickened. So if you put silver stain or you put PAS stain, what will you see? So either you put silver stain or you put PAS stain, and what do you see? Okay, so either you put silver stain or PAS stain, and what do you see? You will see spike and dome pattern. Okay, so spike and dome pattern. So if you're seeing spike and dome pattern on silver stain, that is very characteristic of membranous nephropathy. So let's look at this all and we will be able to understand it better. So this is the normal kidney that you're seeing here. Okay, so this is the glomerulus, opened up the lumens. Okay, parietal epithelial cells are perfect, and the normal thickness of the basement membrane is just one pencil thick. Look at this. This is the normal abnormal glomerulus. What do you see here? The basement membranes appear thickened. The basement membrane appears thickened. So there is thickening of the basement membrane all over the glomerulus. So this is very characteristic of membranous nephropathy. Okay, so this is very characteristic of membranous nephropathy. If you do a silver stain on it, so this is how the silver stain appears. It's a black color stain. So you can see that the basement membranes are very clean, one pencil thick, just like the normal one pencil thick, okay, lining. So that's the normal basement membranes. But look at this. What do you see? Here you can see these spikes coming out from them. Okay, here you can see these spikes coming out from the basement membrane. So this is like a spiky boy, which you see the hairstyle of a spiky boy. So this is what is called as spike and dome pattern. So spike and dome pattern is very characteristically seen in membranous nephropathy. Now, if you do the immunofluorescence in this, you will see a granular immunofluorescence. Granular means wherever the immune complexes are deposited, all those parts will start shining. So this is how it will appear. Look at this. Can you see the granules are coming everywhere in the kidney? So this is what is called as a granular immunofluorescence. And if you look at the composition, they are made up of IgG, C1, C2, C3, C4, everything is deposited here. So that's very characteristic of membranous nephropathy. Now, we have talked about the antigen of the membranous nephropathy. It is phospholipase A2 receptor. That's the most common antigen. So recently, new antigen was found. This is either CD10 or thrombospondin type 1 domain containing 7A. Okay, so thrombospondin type 1 domain containing 7A or CD10. So this is the antigen which is typically seen in membranous nephropathy. So phospholipase A2 receptor is the most common, then CD10 and thrombospondin A2 receptor. Okay, thrombospondin type 1 containing type A7A. So that these are the three important antigens seen in membranous nephropathy. Now the next question is, what are the conditions which can be associated with membranous nephropathy? Okay, so conditions that can be associated with membranous could be either drugs like penicillamine, gold, or infections, especially the hepatitis B infections. Okay, especially the hepatitis B infections, schistosomias, malignancy. Now this is very, very important. Remember M for M. Membranous nephropathy is the most common nephropathy to be associated with malignancies. It can be CA breast, it can be CA colon. Okay, so these are commonest nephropathy to be associated with cancers. And autoimmune like SLE kidney. So SLE, we have definitive SLE kidney, but autoimmune conditions can also cause membranous nephropathy. So these are some conditions which are associated with membranous nephropathy, and this you should never ever forget malignancies because it has been asked as a question once. So most common nephropathy to be associated with malignancy is membranous nephropathy. That is one thing which everybody should be super duper clear with, right? Okay, so this is about your nephrotic syndromes that you have to be clear. So we have studied about minimal chain disease. Okay, so we have studied about FSGS and we have studied about membranous. So once you're clear with this, if you looked at the gene here, so the gene with FSGS is ApoL1 gene and the antigen with membranous is phospholipase A2 receptor. So that's most common. Special conditions with nephrotic. Apart from that, you should remember diabetes and SLE kidney are also associated. Diabetes, SLE and amyloidosis also present with nephrotic syndrome. So the hallmark of diabetes, the initial finding, the most earliest finding of diabetic kidney is basement membrane thickening. But the most specific finding is Kimmelstiel-Wilson lesion. So Kimmelstiel-Wilson lesion is a well-defined homogeneous area which is seen in the glomerulus. So once you see this, remember this is your Kimmelstiel-Wilson lesion. Okay, so this is also called as nodular glomerulosclerosis. So these are nodules, okay, which can be seen. So nodular glomerulosclerosis, these nodules are made up of glycogen. So they are pass positive, and because they are made up of glycogen, if you put diastase on it, it will dissolve. So they are diastase sensitive. Okay, so they are pass positive and diastase sensitive. That is Kimmelstiel-Wilson lesion that everybody should be very clear with. Now, what about SLE kidney that you should remember? So SLE kidney typically presents with full house effect. So somebody asks you full house effect is seen in which condition? It is SLE kidney. What do you understand by full house effect? That if you put IgG, IgA, IgM, C3, C1q and fibrinogen, all of them will come positive. This is what is called as full house effect, and this is very typically seen in SLE kidney. So full house effect is a very typical condition which is seen in SLE kidney, right? So that is about your diabetic and SLE, which you should remember. A myeloid kidney, usually they don't give you an image, but if they give you, the basement membranes of the blood vessels are also thickened along with the extracellular amyloid deposits. Okay, so usually a myeloid kidney is not given as an image. Okay, so just you have to remember a myeloid kidney presents like nephrotic syndrome, right? So with that, these are the common conditions of nephrotic syndrome which everybody should be clear.